The topic of this discussion is allergic conjunctivitis. Starting with introduction, ATP is a genetically determined predisposition to hypersensitivity reactions upon exposure to specific environmental antigens. Clinical manifestations include the various forms of allergic conjunctivitis as well as hay fever, which is seasonal allergic rhinitis, asthma, and eczema. Allergic conjunctivitis is a type 1 immediate hypersensitivity reaction mediated by degranulation of mast cells in response to the action of IgE. There is evidence of an element of type 4 hypersensitivity in at least some forms. The first type we are going to discuss here is acute allergic conjunctivitis. Now, it is a common allergic condition caused by acute conjunctival reaction to an environmental allergen, usually pollen. It is typically seen in younger children after playing outside in spring or summer. Acute itching and watering are common, but the hallmark is chemosis, as it is seen in the pictures. The first picture shows swelling of conjunctiva, and it is in extreme form in the second picture. This chemosis is frequently dramatic and worrying to the child and parents. Treatment is not usually required, and conjunctival swelling settles within hours as acute increase in vascular permeability resolves. Cool compresses can be used, and a single drop of adrenaline, 0.1%, may reduce extreme chemosis. Then is seasonal and perennial allergic conjunctivitis. These common subacute conditions are distinguished from each other by the timing of exacerbation, thought to relate principally to different stimulating allergen in each. Seasonal allergic conjunctivitis or hay fever eyes, worse during the spring and summer and are more common. The most frequent allergens are tree and grass pollens, although the specific allergen varies with geographical location. Perennial allergic conjunctivitis causes symptoms throughout the year, generally worse in the autumn when exposure to house dust mites, animal dander, and fungal allergen is the greatest. It is less common and tends to be milder than the seasonal form. Diagnosis is based on symptoms, signs, and investigations. Symptoms include transient, acute, or subacute attacks of redness, watering, and itching associated with sneezing and nasal discharge. Signs include normal vision, conjunctival hyperemia with a relatively mild papillary reaction, variable chemosis, and lid edema. Investigations are generally not performed, although conjunctival scraping in more active cases may demonstrate the presence of eosinophils. Skin testing for particular antigens is rarely required. Treatment includes artificial tears for mild symptoms, mast cell stabilizers, for example, sodium chromoglycate, nitrochromal sodium, rhodoxamide, and these must be used for a few days before exerting maximal effect, and they are suitable for the long-term use, except for the rhodoxamide. Antihistamine, for example, amidestine, epinestine, Levocavestin, bepotestin, can be used for symptomatic exacerbations and are effective as mast cell stabilizers. Dual action antihistamine and mast cell stabilizer, for example, azelastine, ketotifen, and olopatadine, act rapidly and are often very effective for exacerbations. Combined preparations of an antihistamine and a vasoconstrictor, for example, entazavine with xylometazoline. Then non-steroidal anti-inflammatory preparations, for example, diclofenac, can provide symptomatic relief but are rarely used. Topical steroids are effective but rarely necessary. Oral antihistamines may be indicated for severe symptoms. Some, such as diphenhydramine, cause significant drowsiness and may be useful in aiding sleep. Others, such as loratadine, have a far less marked sedative action. So this is where we'll be concluding the topic of allergic conjunctivitis. We'll be discussing other types of allergic conjunctivitis in detail in the upcoming lectures. Thank you all. If you like the lecture, please click on the like button and subscribe to the channel.